My name is Caio Villela. I am a software electrical engineer here at Google. And on September 9th, I had a heart attack, so I just thought I would share the experience and the stuff that I learned. So we'll start out with the symptoms, which is quite freaky because I didn't have my chest on fire or anything like that. I came to work. Regular Tuesday. After that, had a bike ride with my friend Dave. Actually, quite a long ride, more than an hour for sure. And came home feeling kind of like maybe the beginning of a cold, which turned into a little bit of a chest tightness and shortness of breath. I also had hurt my finger in the lab earlier in the day. So I was having pain on my left arm, but I thought it was because of my left thumb. So my wife took one look at me and said, you don't look very good. Let's go to the hospital. And I said, no. And he goes, well, what are your symptoms? And I said, well, tightness, shortness of breath, and my left arm is, yeah, that doesn't sound good, does it? So she called my dad, which is a cardiologist, and he said, get in the car now. So this is like a good first point because the symptoms can be very deceiving. And they say when you have a heart attack, that first hour is like the golden hour because if you can fix it before a whole bunch of damage occurs, then there's not, it's not a huge problem. But if you wait or in an inaccessible place and whatever, then things can get pretty hairy. So I went to the Good Samaritan Hospital in Los Gatos, excellent hospital. My wife dropped me at the emergency and said, I'm going to go park the car. By the time she came back, I was already in the gurney. They already had done an electrocardiogram. They already knew I was having a heart attack. So the response was phenomenal. So I'm not going to do an explanation on EKG because that would take probably several hours. And it's a complicated exam to understand. But the one thing I want to communicate is that the EKG has these paths, electrical paths. So any EKG will have 12 blocks of information, which are different paths to the heart. And depending on the one block that looks bad, the doctor can determine which area of the heart is suffering. In my case, was the V3, which was the bottom part of the left ventricle. So the doctor knew that there was a problem there. So most of this presentation is going to be going through the films that the doctor gave me for the procedure, the actual procedure of unblocking the heart and putting the stent. But I think just to have a point of reference is going to be good to go through a couple basic concepts that, at least for me, was forgotten from high school days and everything. So forget about the blue part. Just look at the red part because I was having a problem on the left ventricle. The heart has 4 valves, and there's 2 here that are on the red circuit. And you have the mitral valve and the aortic valve. So from the previous beating, blood fills in the 2 chambers. Then the atrium contracts, increasing the pressure on the left ventricle. Once you have the left ventricle nicely filled, the mitral valve closes, the aortic valve opens, and then the left ventricle contracts. So why was I having shortness of breath? The shortness of breath happens because when cells are dying, the dying cells can initiate a beat. Each cell in the heart is capable of contraction, and after the contraction, there's a period of time, like what they call a rest time, and then there's a window where if you excite it, it will beat, it will contract. So if some bad cells are initiating a beat at the wrong time, then you have a contraction of the left ventricle that occurs while it's not completely filled up. So you have like a weak beat going on. And then the next beat will have more time for it to fill up, so it's going to fill up a lot, so it's going to be hard for it to push. And since it already has some cells with damage, it starts beating irregularly, and then blood starts backing up at the lung. So this is like a weird sensation because I could not take deep breaths. I could only do like short, fast breaths. So because the area was the bottom of the left ventricle that was having problems, chances were that the problem was on the left anterior descending, also called the LAD. So the left coronary that starts off right at the top there branches off in two into the circumflex in the left anterior, and then that branches, the circumflex branches again into a diagonal, and then the circumflex itself that has 3 or 4 branches depending on the person, I guess. It's important to kind of remember this as a map because with the film, that's what's going to be showing, right? And so here's another view of going over a little bit to the right, where you can see more of the circumflex and the LAD. So let's start here. So this is the very first film that the doctor did. So at 7:20 was when I felt bad and went over to the hospital. And this is happening at 9:53. So two and a half hours later, I was already getting some good attention. So what these films are going to show are the following. The doctor is going to put the catheter right where the arrow left coronary artery is. And he's going to throw some dye, which is this liquid iodine base that shows up on X-ray. And he wants to see that map there, so if there's parts of it missing, that's where the problem is. So you got to have an educated eye in order to be able to see this stuff. So over here, he's seeing the diagonal and the circumflex, and there's no LAD. This is not the best angle. So let's go to the next one. This is also a not so good angle. So I'm just going to flip through all of them. And so on this one here, you can see that there's a huge part there missing, which, yes. So this branch here, right there, is the circumflex and the diagonal artery. The LAD should start a little bit lower than where the catheter is.
Can you stop the video and pause it?
Yes. So we should be seeing something like coming down here. So actually, why don't I do this? Let me go to number 10, I believe. Let's see what number 10 shows us. And then I'll come back. So the doctor's trying to find where the LAD is. So here's another picture. See if I get a little better. And so the catheter is a piece of plastic tubing that gets inserted in the crotch. And by using a guide, which is sort of a guitar string that has a hook at the end. The doctor, by pushing and pulling and twisting, and since he knows the map, he knows how to get there. So once there, he uses the guide to look for the missing artery. So in this case here, we see the tip of the guide here, and we can see that he found the LAD. So the first pictures are all trying to take a look around. So let's go real quick through them, because the doctor also wants to see if there is other things that are wrong. So here's a good picture of the circumflex, and there is a problem. Let me use the mouse. There's a problem right here. The last branch of the circumflex has an obstruction here of about 90%. Now, this is not the time to fix that one. The doctor will determine what has 100% blockage and is causing damage, fix that, wait typically 3 to 4 weeks to get that area to heal nicely, and then schedule another procedure to take care of whatever else is wrong that he can see there. Let's see what we can see on this one. So on this picture, we can see better how there's very little flow from the circumflex to the last branch here. Well, there's still some, so nothing is dying, but this is definitely something that needs to be fixed. Another picture of the same. Now, on these takes, obviously we can see the problem with the circumflex, but what he's doing is he's using the guide and looking for the LAD. He wants to get the guide inside the LAD. Let's go to number 9. Now this picture is great because the LAD should come out, and we're going to see after he unblocks it, should come out here. So this whole area here is not getting any love whatsoever at this point. So on number 10 again, we can see that the guide is now inside the LAD. So this is another interesting picture. So now that the guide is inside the LAD, and you can see the 2 markers there, what he's going to try to do is to open up the obstruction by using a balloon that's smaller. It's 2 millimeter diameter, smaller than what the final stent, which is 3 millimeter, will be. Just kind of to feel it first. Also, to determine what is the location of the obstruction. So if he inflates in one area, then he can see what the effect is. And if that doesn't do the trick, or it does partially, then he moves a little further down and then do it again. And that way he can determine, that's how you determine where the obstruction is. So here he's inflating the balloon on take number 12. Now on this take, now we can see that the LAD is beginning to show, but it's still pretty weak. So now he moves down the balloon a little bit and inflates it again. And now it's looking a lot better. So this is interesting. While I was on emergency, the nurse kept asking me, okay, what's your pain level from 1 to 10? And I said, not really feeling any pain. I'm kind of have like a discomfort, right? Sort of like a tightening sensation is the. And he goes, well, what is it? Is it 0? I said, no, it's not 0. Maybe it's a 1. Okay, morphine. And I said, please, no more morphine. I want to kind of be awake and be able to see the doctor doing this stuff. And anyways, I was not myself when this was happening. That's all I can say.
So what's the thickness of the probe versus the arteries?
So the stents that they put in, the 2 stents that were placed, they were 3 centimeters. So 1 inch is 2.54, right? So it's a little over an inch in length and 3 millimeter in diameter. So over here, he's rotating just to make sure that he's got a nice angle. Let's see what 18 shows. Yeah, no change there. So I'm not positive about this, but I think that is the case. After the doctor puts the balloon, and up until 1990 something, that's all that they did, right? They would go in, try to spread the plaque around the vessel, and there you go. A lot of times that plaque kind of has a memory and then comes back and obstructs again. In this case, it happened really quickly. I mean, on the previous film, it got blocked again just a few minutes later. So now what we see here between, let me stop this, between this point and this point is where the stent is going to go. The stents, maybe I should talk a little bit about stents. Let me just finish this. So here's the balloon with the stent being inflated on take number 20. And here's take 21, and let's say 22. There you go. This is the end of the first procedure. You can see that he makes a sort of an angle here where the end of the stent is, but the stent is going from here to here. So let's see here. So the idea of the stents and the picture up on top is the old style stent. Basically, you get a metal tubing of the diameter that you want its final position to be, and with a laser or some other method, you etch out the holes. Then you compress that into the catheter and with a balloon inside. The stents are getting very high tech, and this is like a mechanical marvel. The stent that they were putting in me was the Cypher, which is this guy here. And I even have a little animation on when you inflate the balloon, what happens to the stent. So it goes in compressed like that, and it's put in place, and then it opens up, and that's how it works. Let's see what else I have here.
So you got thrown on the journey, they're starting to look at you and stuff. From a sort of a legal standpoint, is your wife out there being asked to sign 550 forms? Because it sounds like you're doing angio and stents.
Yes.
That within 2 hours of you rolling in on the journey, not like come back in 3 days and we'll do a surgery.
Right. Yeah, she did have to sign it. I was conscientious when I came in, so I don't believe I had to sign anything myself, though. I think she did sign everything. But so this is it as far as the first procedure. This happened on a Tuesday night, so by Friday afternoon, I was sent home. And I was having, as the heart scars, in other words, the cells that had damage, the doctor estimated that off my left ventricle, I had a 6 to 8% damage. And that, and you can determine that by several things, one of which is the amount of enzymes that the dying cells put out, and they can pick that up in the blood. So the idea then was to send me home, don't do anything, just be, very quiet. And then after 4 days, I could start walking. And the plan was to wait 3 weeks, come back to do the circumflex, to do that guy there, that's at 90%. So Tuesday, exactly a week later, I was bored out of my mind, and my dad is a cardiologist, and he was here, so I said, Dad, let's go to the mall or something, right? Let's walk around a little bit. And I walked at Valley Fair from one end to the other, and by the time I got to the other end, I was not feeling well at all. I was having sort of the same tightness, shortness of breath again. Told that to my dad. He ran over to pick up the car, and I walked to the street to have him pick me up, and by the time I walked from the mall, just like, 30 yards to the street, I was looking for a place to land. And there was a chair there, so I landed on the chair. And my dad picked me up, and I said, let's go right back to the hospital. Sorry. So what happened there was I was taking a drug called metoprolol, which is a drug that is called a beta blocker, and has the effect of slowing down the heart, reducing your blood pressure, and so you can faint, I guess, and not have the blood being pumped up. So they did another electrocardiogram and everything, and I said, everything looks good. It's not really a problem, but since you're here, why don't we do the other one right now? So I said, sure. I actually wanted to just get it over with, right? So let's go. So give me a minute here. We'll go for the second one. The second one is actually very interesting because I think I have to do this. Okay, there we go. I agree. So from the first film, we see that 90% obstruction is right at a junction, and actually the middle branch is actually bigger than the smaller last branch. So there's something called the snowplow effect, which is, if you unobstruct a vessel here and then you push that plaque over, you may block, let's see if we can see this. So what we don't want is putting a stent here and then blocking up this guy that's healthy. And there's a very high risk, nice picture of the stent that was put a week before. Over here. So he's going to have to do a pretty nifty trick in order to prevent that from happening. And the trick is he's going to put one guide going this way, one guide going this way. He's going to inflate a balloon here, and then inflate the stent with the balloon here. So this is actually two And we're going to be able to see this in a second here. Let's see.
Are you saying it's going to put in 2 stints?
No, it's 2 guides. So the guide is, like I said, a guitar string. The interesting thing about, let's see here. Yeah, let me go to the next one. So here's the first guide. So the guide is a guitar string.
So the guide is actually hollow?
No, imagine a guitar string. A guitar string has a solid core and a wound part outside. If you make the solid core smaller, slightly smaller than the wound, and then you solder the tips, you're going to cause a hook that you can actually shape. And the doctor has a palette of different shaped tips in his disposal, right? So over here, you can see they also coat the tip of the guide with these cobalt thing, whatever. So it gets a little bit darker so you can see where the tip is. So the tip of the first guide is over here. That's the one that we want to deobstruct. And here is the tip of the second guide, and that's the one that we want to make sure that stays open. So let me play that again. Boy, sorry. 14 is going to be, let's see. So I guess you guys can see, right? So at first, again, he's using a smaller balloon just to get things going, make sure that nothing explodes, I guess, on the area that has a problem, and then make sure that it does the trick. And it looks better, but I don't know if it looks perfect. It looks better. And you can also see the little cobalt markers where the balloon is going to go from here to there, and then the another one from there to there. Okay, I think this is the. I don't know if it's possible to see when it's repeating, but there are 2 balloons, one on the middle one and one on the last branch. Okay, here's the yeah. When you use the balloon, but it's just for a few seconds, so it's certainly no problem to stop the blood flow for a few seconds. So on this one, you can clearly see, right? You can see where he placed a tiny balloon here on the one that he doesn't want blocked, and here is the stent being placed. So this is actually the stent being placed.
Are there actually 2 guitar strings there?
Yes. You have to, because you have a balloon on one and a balloon with the stent on the other one. A guide is what they call it.
Just using your terminology.
Yeah. And then here is just going to be some more pictures to make sure that everything is nice. So here it is with the stent. Looks really good. And here's my LED with a stent that goes from here to there. The LED is going on the other side. Right now, the foreground is on the circumflex, and the LED is the other side. But you can see the sharp turn here is where the end of the stent is, and then this guy here is going about from here to about there. So let's see. the conclusions on this. Yes, Chris.
Sorry about the silly question. So it's not, the problem wasn't that the heart wasn't pumping blood, but the blood for the heart itself was all right?
Yes, the coronaries are the arteries that provide blood to the heart muscle. And for some reason, they have this tendency of getting blocked up. Really be great if it got blocked up in a finger or on the leg or something. But, you know, unfortunately, it's in there. So, well, I mean, brain is another one, right? Stroke. So my first question was, you know, why me? I exercise. I'm a little chubby, but I'm not that overweight, and I don't smoke, and I don't do drugs. So I'm not diabetic. And I don't have high blood pressure either. So all that I have is high cholesterol and family history. So my grandfather from my mother's side died at 59. I'm 49. And I would have died probably if I didn't have this procedure that I just showed done. So the answer then is definitely genes, and my diet was not perfect, so this little scare served to fix my diet actually real good. So now it's like salad and fish and chicken. Things that I could have done differently is maybe have a little bit less stress and be a little lighter in weight. But other than that, I don't know what else. And I probably would have had something eventually. I'm taking 2 kinds of drugs, actually 3 if you count aspirin. But I take an aspirin a day, and that's going to be for the rest of my life. I'm taking Plavix, which is a blood thinner. So when stents started being put in the early 90s, there was incidence of restenosis, which is the reblockage, reblocking exactly where you put the stent, of about, depending on which study, on who you ask, between 25 and 35%. So that's a pretty high percentage of failure. And the problem with that was that when you have a heart attack, on most cases is you have some time, because you have an obstruction that kind of progresses to, like a 90% to 95%, and then you start getting some symptoms. So you have time to act. When a stent goes through the restenosis or reblocking, usually it's fatal. So it was a bad odds a little bit on the beginning of the stent age. So this stent that was put in on these 2 procedures is called a drug-eluting stent. And what that means is that the stent is made out of steel, 316 steel, but then they coat it with a anticoagulant that gets released at a course of 6 months. And during 6 months, the tissue of the artery will grow over the stent and then greatly reduce the risk. So my biggest risk is in the next 4 or 5 months. And that's why I take Plavix. Plavix is a blood thinner. It makes it, I got to be very careful not to get cut. I mean, I cut one time shaving on a Friday. On Monday, I was still bleeding. So it's a tough deal there. But I'll get off that soon enough. So it's not forever. And then the other drug that I'm taking is simvastatin, which is a statin. And a statin is a drug that is very recommended for people that have high cholesterol, because it prevents the body from making cholesterol. So in a case like mine, where my cholesterol was about 275, even if I had a diet of 100% lettuce, the body would still make a bunch of cholesterol, and my cholesterol would probably go to a reasonable level, but it would be incredibly difficult to control my cholesterol level just by diet. So with the statin, we're hoping that it's going to go from 275. My doctor wants it to be below 150. So, and Another thing that I'm going to have to be differently is exercising. No more of the super strenuous bike rides that I was doing. Sometimes Dave and I were going on weekends and doing like 3-hour rides on places like Heart Attack Hill. And I don't think I'm going to be doing that anymore, unfortunately, because that was fun. I am supposed now to control my heart rate when I exercise and never let it go above 128, 130. This is a good thing to, this rule of thumb is you get 220 minus your age, that's your 100% level. And then if you're above 50, you shouldn't go above 70% level. So 70% of that is around 128. So now I have one of those polar things, and when I'm exercising, I'm making sure that I'm not going over that amount. This is pretty much it. Questions?
Did you feel anything at all before this happened? Thinking back, did you say there was something going on?
Did I feel anything before this happened? Well, I did know that because of my grandfather died at a somewhat early age, that I need to keep a tab on it. So every 2 or 3 years, I do an electrocardiogram, and I've been measuring my cholesterol. My dad has been giving me a really hard time because, of course, he's not happy of me having a 275 level. He wanted me to start statins about 2 years ago, and I said, I'll try to get my diet better. I don't want to be taking pills yet. But heart attacks is one of those things where 1 minute you're good, and the next minute you're not. So the nice thing, or the positive of this is that in about 5 or 6 months, I'm hoping to be actually in better health than I was before.
How come you mentioned you're taking aspirin every day? That's because it's blood thinning, right?
Yes, the aspirin every day is for blood thinning purposes, in addition to the Plavix. Yeah, I'm taking both because they want it real thin right now to not have the blockage. So just to finish off on what I was saying on the drug-eluting stent. The drug-eluting stent caused that 25 to 35% of failure go down to about 7 to 8%. And what my dad told me is that if I am absolutely religious about not ever missing a Plavix, so I have to take that every day, my risk is really around 2%. So that's what I'm hoping. There's 2, right? So you got to multiply those percentages.
Yeah, a comment and a question. First,
If I may.
oh, thank you. A comment and a question. First, I'd like to point out that nearly 30% of all heart attacks are silent heart attacks, meaning that the only symptom that you ever get is they take an EKG and they say, oh, you've had a heart attack at some point in the past. So I'm an example of one of those. But the question was, you mentioned the golden hour and the fact that you had 6 to 8% damage. Does that mean the golden hour wasn't long enough for you, or that you didn't make it in time?
No, I mean, what that means is that if that procedure was done 5 hours later, I would have had a lot more damage. And if it was done actually 1 hour earlier, I'd probably have no damage at all. So the amount of damage is proportional to the amount of time that you have your cells not gaining any blood. So that is why it's so important to, if you have the symptoms, to go and get an EKG.
Comment, Kyle.
Can you?
Yeah, I can. I think what's really kind of interesting here is that when Caio and I were riding on that day that he had his heart attack, now I didn't know about it because I'd already left his house when he called me later, I guess the next day, and said, hey, I had a heart attack. I'm going, holy crap. But What the interesting sign for Kyle was the fact that he complained about being tired. Now, we've been riding a lot for about, I guess, 6 months or maybe longer, probably a couple times a week. And so I got to know pretty well. He was constantly, the whole ride and start, I'm tired, I don't feel good. So we actually turned around early, which is kind of thankful because usually, as Grant knows, we're over there, what's that area called? Over there? Saratoga Gap. And you can get pretty far out in Saratoga Gap. So it's ironic that at least this time, because he was, really tired, I'd have to say definitely more tired than usual. The sucko part is he still beat me back, which is kind of odd, but you would think I'd get an advantage there. But so it seems that the precursor, at least in his case, is the fact that fatigue. I mean, more so than what you'd normally measure. So I guess if my barometer moving forward is if I'm ever feeling that tired, I'll definitely keep an eye on myself, that's for sure.
Well, I mean, I hope I have given you a good perspective. I don't want to freak everybody out, although tomorrow is Halloween, so I guess I'm entitled to.
Yeah, thanks, Kyle.
So do they have anything to, basically, drugs to eat away plaque?
I'm sorry?
Do they have drugs to eat away plaque? I guess the answer is no, but are they working on it?
No, I'm not aware of that.
I mean, TPA is an example of one, but I think one thing that happens with those sometimes is they'll dissolve pieces of the plaque, which will then get loose and just go plug something else up. And in particular, they can cause a stroke if they go up into a artery in your brain. And so they usually don't like to use drugs like that unless, there's no alternative.
So what the stent did is just push the plaque against the wall, right? So it's still there? The plaque's still there?
Yes. On this picture, you can see that you restore the diameter of the vessel. The artery is kind of stretched up, and that's why the doctor used a 2 millimeter first and then a 3 to kind of, gently enlarge. The outside diameter of that vessel is enlarged. And of course, with time, as long as it doesn't rupture when you're doing it. If you ruptures while you're doing it, then I would have been willed over to open heart surgery, right? Then they would have to do a bypass. But as long as that doesn't happen, then you will recover with time and.
So, but the plaque is still there, and it's
Pushed out.
Oh, it's pushed out.
Yeah. Yeah.
Oh, okay, out against the wall.
All right. Well, thank you very much.
We're happy that you're here, Caio.
I'm sorry?
We're happy that you're here.
Me too.